I'm Dr. Person, Health Officer for Benton-Franklin Health District. And at the last Board of Health meeting, I was asked to address two issues. Next slide, please. So the questions to be addressed are COVID-19 immunity, so effectiveness of either post-vaccination or post-infection immunity in reducing morbidity and mortality due to COVID-19. And the second is on COVID-19 masking, the effectiveness of masking to reduce transmission. So I'm happy to provide this information to help the Board of Health to fulfill their duties as outlined under the RCW 70.05.060, item 4, which is to provide for the control and prevention of any dangerous, contagious, or infectious diseases within the jurisdiction of the local health department. Next slide, please. While this is a formal presentation, I do just want to remind the Board of Health that on several prior board meetings last year, I did provide summaries on the effectiveness and efficacy of vaccines, as well as direct them to available resources online. Next slide, please. I'll begin by discussing the effectiveness of either vaccination or post-infection immunity in reducing morbidity and mortality. Next slide, please. As a reminder, the Centers for Disease Control and Prevention have provided some fairly extensive science briefs, which for vaccines include nearly 300 references. And just to be clear, these references do not include only studies conducted by the CDC or on behalf of the CDC, but include a wide range of ongoing research. So some of the key findings that are outlined in these briefs show that fully vaccinated and up-to-date vaccinated individuals and those previously infected with SARS-CoV-2 each have a low risk of subsequent infection for at least 6 months. Data are presently insufficient to determine an antibody titer threshold that indicates when an individual is protected from infection. And at this time, there are no FDA authorized or approved tests that the provider or public can use to reliably determine whether a person is protected from infection. So immunity provided by vaccine or prior infection are both high, but not complete. While studies have shown that antibody titers correlate with protection at a population level, we do not know what the protective titers at an individual level are. Whereas there's a wide range in antibody titers in response to infection with SARS-CoV-2, the completion of a primary series, especially with the mRNA vaccines, typically leads to a more consistent and higher titer initial antibody response. For certain populations, particularly the elderly or immunocompromised, those levels of protection may be reduced following either vaccination or infection. And current evidence indicates that the level of protection is not the same for all viral variants. The body of evidence for infection-induced immunity is more limited than that of vaccine-induced immunity in terms of the quality of evidence, predominantly the bias towards symptomatic or medically attended infections versus asymptomatic. There are insufficient data to extend the findings related to the infection-induced immunity at this time to persons with very mild or asymptomatic infection. We anticipate that we will continue to see evidence and data arise through the ongoing variants that we are seeing and the ongoing monitoring that is occurring post-vaccination. Next slide, please. So I wanted to touch a little more on the concept of infection and immunity. So as I discussed at the December Board of Health meeting, while infection-induced immunity can provide protection, not all infection leads to immunity. The first reference I have here cites studies that range from 5% to 85% of individuals who tested positive for COVID-19, but did not demonstrate subsequent antibody development. I will say this is not unique to SARS-CoV-2, the virus that causes COVID-19. It can be seen with a variety of other viral respiratory infections, although not all. It is also common with many bacterial infections. For example, strep throat or urinary tract infections due to E. coli can commonly recur. So again, infection does not guarantee immunity. Next slide, please. So the other unfortunate aspect is that level of antibody development post-infection does appear to be related to severity. So those with the most severe disease produce the highest levels of antibody. Again, this is not an ideal situation in terms of looking for a mechanism to increase immunity in a population. So this slide is from the third study that is referenced on the previous slide. Again, the green lines are those who had severe disease. The blue lines are those who are asymptomatic. And as can be seen, even a couple of months post-infection, those who were asymptomatic, over 70 or only 70% of them demonstrated seropositivity. Next slide, please. Evidence from South Africa is also showing us that we are seeing increasing numbers of persons with not just one reinfection, but multiple reinfections. So their data, they looked at 35,670 individuals with at least 2 suspected infections through the end of November, 332 individuals with a suspected 3rd infection, and 1 individual with 4 infections. The recent spread of the Omicron variant, what has interestingly been noted was that they were seeing an increase in relative numbers of people who were reinfected versus those who had a primary infection. While it is not yet known what this is due to, the authors do postulate that it may be related to the fact that individuals who are vaccinated and have protection were less likely to be infected compared to those whose only immunity was due to prior infection. So where you can see the red arrow, as you can see with that most recent wave due to Omicron, that they were seeing a significantly increased signal for individuals who had not been infected just once or not even having their first reinfection, but were again reinfected multiple times. Next slide, please. What we also know is that vaccination has been highly successful in reducing mortality due to COVID-19. So several studies have demonstrated this efficacy in reducing deaths as well as hospitalizations. Next slide, please. So from the Commonwealth Fund brief, they identified that vaccination, that without vaccination, there would have been 3.2 times higher number of deaths in the United States, resulting in an additional 1.1 million individuals who would have died as a result of COVID. Peak deaths daily due to COVID would have reached 21,000 compared to the 4,000 that was seen during the Delta wave. As this graph demonstrates, the difference is most notable when infection rates are highest, as we saw in the peak post-Delta. This is prior to our current Omicron wave. So again, we may see differing data with this new variant. Next slide, please. This evidence is not limited to the United States. From the European surveillance, they also identified that countries with the highest vaccination rates showed the greatest reduction in expected deaths due to COVID. Next slide, please. This one's probably going to be a little bit difficult to see because of the number of countries that they are presenting, but I encourage you to take a look at that reference. You can see in Iceland, where 100% of their population age 60 and older was fully vaccinated against COVID-19, they averted 93% of deaths in that age, compared to the country that was had the lowest level of vaccination, the Ukraine, with 20% of their 60 plus population vaccinated, only saw a 6% decrease in deaths averted due to COVID-19. Excuse me. Next slide, please. The benefits from vaccine are not limited to reduction in deaths. They also saw a reduction in hospitalizations, as the following studies will elucidate. Next slide, please. So again, from the Commonwealth Fund research report, estimated that hospitalizations were decreased by 4.9 times, averting potentially 10.3 million hospitalizations. This is a staggering number if we consider that in the United States, the usual hospitalizations per year are 36 million. So an increase of 1/3 that number clearly would have crippled our healthcare systems. Next slide, please. From the Medicare data, the Department of Health and Human Services evaluated the associations between county level vaccination rates and COVID-19 outcomes in Medicare beneficiaries. They estimate that in Medicare beneficiaries saw a decrease of 265,000 infections, 107,000 hospitalizations, and 39,000 deaths as a result of vaccination. What is most striking as well is that it is not purely due to vaccination of individuals age 65 and older. Vaccination rates in the 18 to 64-year-olds also influenced the rates of death and hospitalization and infections in the Medicare population. So counties where there was relative 10% increase in those adults age 18 to 64 who were vaccinated, there was a subsequent 11% decrease and 11% decrease in hospitalizations among Medicare recipients and 12% decrease in deaths. So again, this is why we vaccinate all and not just those at high risk. Impacts are seen not just in the elderly and most vulnerable populations. Next slide, please. Yes, so even among children and adolescents, comparing states with low levels of vaccination to those with high levels, there was an increase 4 times hospitalizations in the month of August. Of those children and adolescents who were hospitalized, about 20% of them spend time in the intensive care unit. So these are not just individuals who are admitted with an attached diagnosis of COVID. These are individuals who are gravely ill. Next slide, please. COVID-19 vaccination protects against multisystem inflammatory syndrome in children, which is among the more severe complications that can be seen as a result of COVID-19 infection in children. So vaccination reduced that likelihood by 91%. Adolescents who were hospitalized with multisystem inflammatory syndrome in children, 95% of them were unvaccinated. So yes, there were some who were vaccinated who did develop this, but the majority was the unvaccinated. And most importantly, no vaccinated MIS-C patients required life support compared to 39% of those who were unvaccinated. So again, complications in children and adolescents are less likely than in adults, but that does not mean that no children or adolescents are affected by COVID-19. Next slide, please. Finally, a study of hospitalized patients with COVID-19 like illness found that unvaccinated individuals with previous infection were more likely to be hospitalized and to test positive again for COVID-19 compared to unvaccinated, supporting that vaccination provides a more durable protection against the more severe consequences of COVID-19, namely hospitalization or death. Next slide, please. Next, I will address COVID-19 masking, the effectiveness of masking to reduce transmission. Next slide, please. So I want to talk a little bit about the physics of filtration and transmission, again, to provide information on why masks would be effective, as well as some additional information to show that in communities with higher levels of masking, we did see reduction in COVID-19 disease rates. Next slide, please. So first, I do want to talk a little bit about particle size, because I have heard people in the same conversation say that masks are ineffective at blocking viral particles, but do not allow oxygen or carbon dioxide to be inhaled and exhaled correctly. So just to point out, the standard size of a SARS-CoV-2 viral particle is about 200 nanometers or 0.2 microns. A carbon dioxide molecule or an oxygen molecule, those are on the size of picomicrons. So again, about 300 times smaller than a SARS-CoV-2 molecule. Next slide, please. Respiratory droplets, on the other hand, are about 10 times larger than the SARS-CoV-2 viral particle. And the predominant effect of masks is to block those respiratory droplets. Another way that we could put this into a size perspective is that a respiratory droplet would be about the size of a cardboard moving box, so about a yardstick on each dimension. SARS-CoV-2 viral particle would be about the size of a baseball, and then oxygen or carbon dioxide molecules would be about the size of a human hair. So again, this is why masks can be effective in blocking or filtering respiratory droplets, aerosols, even viral particles without blocking the flow of oxygen or carbon dioxide. Next slide, please. So mask efficiency does correlate to particle size. So again, masks work best to limit the spread of those respiratory droplets or aerosols. The dark blue line, those are the N95 respirators, which are of course the most effective. By definition, they need to be able to filter 95% of those particles. But even procedure masks and cloth masks can provide protection, although as particle size goes down, their efficiency goes down as well. Next slide, please. So this was from the, a fact sheet on the importance of using the proper equipment. And so we can see that if a source who has COVID-19 is not wearing anything and receiver is not wearing anything, the time to infectious dose is 15 minutes. If both are wearing cloth masks, that is nearly doubled to 27 minutes. If both are wearing N95s, then we can see that protective time increases almost exponentially. It's important to note from this that masks are not expected to be 100% effective in blocking spread. That is why we use a layered approach with multiple means of protection and of reducing spread. There are very few things in public health where a single intervention will be 100% effective. We know this is true even of things like seatbelts, which we know are incredibly effective in protecting people from serious injury or death due to a motor vehicle collision. However, a seatbelt is not going to protect someone necessarily if they are in a car without functioning brakes, if they are speeding down an ice-covered highway, or if they're on their phone and a distracted driver. So public health works best when we use the full complement of protective interventions. And for preventing the spread of respiratory viruses, this does include the use of masks. Next slide, please. So again, as I have on prior Board of Health meetings, I would again refer the board members to look at CDC's science brief on the community use of masks to control the spread of SARS-CoV-2, which includes a total of 90 references, not just from CDC work, but from other researchers as well, and includes a variety of study types as well. Next slide, please. So it includes cohort and case control studies. So I have listed the author and then the reference number, again, referring back to CDC's science brief. So again, in these cohort and case control studies, we see that masking reduced infection by 70%, by 79%. Always having used mask reduced infection by 77%. No COVID-19 infections seen among patrons who were tested as follow-up after a high-risk exposure of a hairdresser who had COVID, wore a mask, and her patrons wore masks as well. Next slide, please. They also include population level community studies. These are ones which look at COVID-19 rates following implementation of interventions, which include masking. These are both within communities themselves, as well as several studies in schools. Next slide, please. And again, this is not data limited to the United States. From the British Medical Journal, did a systematic review and meta-analysis on the effectiveness of public health measures in reducing the incidence of COVID-19. Next slide, please. And this is just an infographic from the British Medical Journal outlining their results. I want to point out that mask wearing reduced risk by 50%. It's also important to note is that it did not cross the number one. Studies where the confidence interval does cross one, whether you're looking at something lower or something higher, does mean that not all of those results may be as a result of that intervention, but mask wearing clearly is below the number one. Next slide, please. So mask requirements in K-12 schools limited COVID-19 outbreaks. This is from a study published in the MMWR that looked at data from Arizona, the Maricopa Pima School District, which represented approximately 75% of the population in that state. At the time the children went back to school in late July, they were seeing case rates in the low to mid 100s per 100,000 over 14 days. Vaccination rates ranged from 48 to 59%, and data looked at over 100 schools. 2% of the schools did experience an outbreak. There was significant difference between schools where no masks were required, those that required masks at the onset of the school year, and then those that started masks only after outbreaks were identified. So in schools without mask requirements were 3.5 times more likely to have outbreaks compared to those schools that started the school year with a mask requirement. Next slide, please. In counties where states did require masks, case and death rates were slowed compared to those that did not. So again, masking has proven to be beneficial for individuals, schools, organizations, and communities in reducing the spread of COVID-19. Next slide, please. Show the support for use of these interventions comes not just from public health and scientists, but also from numerous professional medical societies who represent millions of providers in the United States have publicly supported vaccination, including mandatory vaccination and masking. Knowing the interest of this board on impact on school-age children, I'd also like to point out that American Academy of Pediatrics is among these organizations as well. Next slide, please. So the American Academy of Pediatrics strongly recommends that anyone over age 2, regardless of vaccination status, wear a well-fitting mask when in public, and recommends vaccination for all children and adults 5 years and older who do not have contraindications. Next slide, please. American Academy of Family Physicians supported universal masking and vaccination as well. Next slide, please. We have similar statements from the American College of Physicians on masking and immunization policies. Next slide. Support from the American College of Obstetricians and Gynecologists for COVID-19 vaccinations, including for women or individuals who are pregnant or test feeding. Next slide, please. And then finally, support also from the American Academy of Neurology. Thank you. That concludes my presentation.